Transverse arrest and posterior positions of the occiput can be very perplexing problems to the inexperienced and beginning obstetrician. Dr. Edward H. Dennen, consultant to the Surgeon General of the Army, will present a discussion of transverse arrest and posterior positions of the occiput and the resolution of these problems by digital, manual, and instrumental means. Dr. Dennen.
Thank you, Colonel Reaver. These maneuvers may be classified as follows. The management, operative for the forceps management of transverse arrest. First, we have manual rotation to anterior, followed by the use of the Simpson type of forceps because of the molding. And this is subdivided into the digital maneuver and the manual maneuver. Second, we have instrumental rotation of the occiput transverse to anterior. This is done with an Elliott type of forceps because the overlapping shanks and the short round cephalic curve of the instrument take up less space and meet fewer points of obstruction during the wandering maneuver of application of the anterior blade. Then we have the instrumental rotation by the special forceps, the Barton and Keeland. These will be taken up at a later time. First, manual rotation, subdivided into digital and manual. In the digital maneuver, which is desirable to be attempted first because there's less risk of displacement of the head, as would accompany insertion of the entire hand, and we wish to preserve station, because the higher the head, the more difficult and more dangerous the operation. In the digital maneuver, the tips of the middle and index fingers are placed at the elevated edge of the anterior parietal bone in the anterior half of the lambdoidal suture, close to the posterior fontanelle, with an elevating, hooking, rotating maneuver. The occiput is rotated around from LOT through LOA and as close to OA as possible. At the same time, the left hand on the fundus is giving counter pressure to prevent displacement and rotating the body inward to facilitate the rotation of the occiput. Once the occiput is around to the anterior positions, the fingers creep around behind the posterior parietal bone to act as a splint to prevent backward rotation of the occiput. Now for the demonstration with the instrument. Tips the index and middle finger against the elevated edge of the anterior parietal bone. The right hand is the rotating hand in left-sided positions. Hooking, elevating, rotating maneuver, counterclockwise toward 12 o'clock. The head is rotated to anterior, aided by the abdominal hand. And then after the fontanelle is as near 12 o'clock as possible, counter pressure is given on the fundus to fix the head in the new position, and the fingers slip around to act as a splint behind the posterior parietal bone and guide the introduction of the first, the posterior, the left blade, to the left ear. And now the anterior blade, inserted in a similar manner to the right side. Locking. checking the application, completing the rotation if necessary to OA, sit down, proceed with traction. Now in the manual maneuver, the one which carries with it the hazard of displacement of the head, because if the head is in the low-mid station, there's not sufficient room to permit the introduction of the entire hand without displacement. However, some heads that are in mid-station or just below, and the hand may be inserted without as much risk of displacement. And the right hand is the rotating hand in left-sided positions. It is inserted palm up over the perineum, the four fingers behind the posterior parietal bone, the thumb in front opposite the anterior parietal bone, gripping the head firmly between the tips of the fingers and the thumb. The left hand is applied to the fundus and the back of the child. And the head is flexed with the vaginal hand, nodding it towards the patient's right side as it is rotated over an arc of about 90 degrees in a counterclockwise direction to anterior. Then the thumb is removed, with the fingers left in place to act as a splint to prevent backward rotation of the head, and also to act as a guide for the introduction of the left blade, the posterior blade, to the left posterior ear. And the right side, right blade, right hand, right side, directly into the right ear. Check the application. And it's found satisfactory, and the head is anterior. Proceed with traction. It's felt desirable to attempt the digital maneuver first in order to avoid the possibility of upward displacement of the head. As a rule, we limit ourselves to the digital procedure, and if that isn't successful, then we proceed with the special type of forceps. However, the other method, instrumental rotation with the classical forceps, is as follows. Here, an Elliott type is used. Preferably the solid blades of Tucker McLean, or those modified by Lucart, in which the fenestration is preserved on the inner side of the solid blade. The instrument is held in position which it'll be after application. And we must keep in mind that in an LOT, the posterior fontanelle is at 3 o'clock, so the anterior surface of the instrument must face in the same direction, and that the shanks must be within a finger's breadth of the posterior fontanelle in order to satisfy the first check of a good application. So, the handles, when applied, will be directed obliquely away from the long axis of the patient because of the pelvic curve. Now, in the application, posterior blade again is inserted first. That's the left blade, because this is a left-sided occiput. The handle is held in the left hand and is inserted directly posterior instead of to the left side because of the pelvic curve. And it'll be noted that the plane of the shank and the handle is directed obliquely away from the perpendicular, as is the position for an LOA. But in the LOT, this is necessarily so, again, because of the pelvic curve. So that the introduction is directly along the whole of the sacrum, behind the posterior parietal bone, and the handle is dropped in a straight line parallel to the perpendicular as the blade passes up in behind the posterior parietal bone. Then the right or anterior blade is inserted by the wandering maneuver, handle of which is held in the right hand, is inserted to the right side, rather high up away from the perineum in order to avoid the posterior frontal eminence. And as the blade passes from view, the handle is dropped well down below that of the posterior blade. And now comes the wandering maneuver with the middle finger replacing the thumb at the heel, lifting that blade around under the symphysis, opposite the anterior cheek. And the handle will be considerably lower than that of the posterior blade already applied, but locking is accomplished readily by simply elevating to the locking level. Next, we check our application, and we find that our handles and the plane of the shanks is within a finger's breadth of the fontanelle, which is desirable. Sagittal suture runs transversely and is at right angles to the plane of the shanks. Of course, no fenestration is felt, but the head on a solid blade, but the head is filling the space between the heels. So we're ready now for the instrumental rotation. And compression, flexion, rotation counterclockwise with depression. Now we check the application, posterior fontanelle, the finger's breadth on the plane of the shanks, the sagittal suture perpendicular throughout, no fenestration felt. And then proceed with traction. As soon as the chin can be controlled with the Ritkin maneuver, the handle is removed, and then the head is extended. And then the forceps removed in the usual manner. For the ROT position, the same procedure is reversed, but the rotating hand is the left hand, and it's necessary to cross the handles in order to lock them, because the lock is on the left shank. Next, we proceed with the posterior positions. Here we have still more maneuvers in order to rotate the occiput posterior to anterior. and they can be classified in a similar manner as for the transverse. We have the manual rotation to anterior, either by the digital or the manual method, followed by the application of the Simpson forceps because of the molding. Or we have the combined manual or digital rotation and instrumental rotation to anterior, using the Elliott forceps for the instrumental part. Then we have the complete instrumental rotation of the occiput posterior to anterior, in which the Scanzoni maneuver and the key and lock maneuver are used. And finally, the special forceps, which will be considered later. In the manual maneuver for rotation of an occiput posterior, first is the digital maneuver, and it's carried out in a similar manner as that for the transverse arrest, except it's necessary to rotate the head over a longer arc from occiput posterior to anterior, an arc of 135 degrees to anterior, instead of from the transverse of only 90 degrees. And the same procedure is carried out, hooking, elevating, rotating around to anterior, and the fingers slip in behind the posterior parietal bone, holding it in place. While the posterior left blade is inserted. Then the anterior blade, the right blade. Check our application. The fontanelle is slightly more than a finger's breadth above the plane of the shanks, so we correct that by elevating the handles one at a time, relocking. Sit down, proceed with traction. With the manual maneuver, again we have the hazard of displacement. However, it is accepted by some on the basis that the head which has been down to a certain level will return to it again without much effort. However, we feel that this is not always true, and when it does happen, it's apt to be in a less favorable position. The right hand's the rotating hand, palm up, thumb in front of the anterior parietal bone, and the LOP is rotated counterclockwise to anterior. Thumb is removed, and the posterior left blade applied to the posterior left ear. That's held in place, acting as a splint, while the anterior right blade is applied. Check the application, complete the rotation to anterior if necessary by compression and depression. Sit down, proceed with traction. Depress the handle so that the suboccipital region can be encouraged to come under the symphysis. and then the head is ready for extension over the perineum. As soon as it's controlled by the Ritgen maneuver, the blades are removed. The next maneuver, the combined manual and instrumental rotation of an occiput posterior to anterior. Here, either by the digital or the manual maneuver, preferably the digital, although it may not be successful in more than 25 or 30% of the time, it avoids that possible hazard of displacement. The head is rotated digitally to an LOT. Resistance to further rotation influences the operator to apply the forceps to a transverse by the wandering maneuver, as has already been described. Here we use the Elliott type of forceps because the overlapping shanks and short round cephalic curve take up less space and meet fewer points of resistance during the application. And the rotating fingers slip behind the posterior parietal bone, holding the head in the new transverse position, and the technique of application for transverse arrest is carried out. And here we have that wandering maneuver, which is facilitated by the use of the Elliott type of forceps. Right under the symphysis, bring up the handle to locking position. Check our application. Rotate counterclockwise over an arc of 90 degrees, compression, flexion, rotation to anterior with depression. Check our application, if make necessary readjustments, and proceed with traction. One might ask, why use an Elliott type of forceps for traction on a molded head? And the answer is, if one anticipates slipping of the Elliott forceps on a long molded head with the forceps not well anchored below the malar eminence, he may remove the Elliott forceps and substitute a Simpson type for the traction, similar to the two forceps maneuver described by Sides. This gives the advantage of a long tapering cephalic curve of the Simpson forceps on a molded head. The next maneuver will be the Scanzoni maneuver. And the choice of instrument is the solid blade Elliott type, the Tucker-McLean forceps. In the Scanzoli maneuver, there is a complete instrumental rotation with a single maneuver, but requiring a double application of the forceps. In the LOP, we consider it temporarily to be an ROA in order to follow the technique of the posterior blade first, so that we'd apply the right blade, held in the right hand, inserted to the right side, opposite the baby's left ear. This is the first exception to the cardinal rule. There's 4 points of left blade, left hand, left side, left ear, because the head is upside down in the posterior position. It's necessary to cross the handles in order to lock them. Depress the handles well down against the perineum in order to have the shanks as close to the posterior fontanelle as possible. Check our application and proceed with rotation. The rotation is counterclockwise in left-sided position and is carried out by combining 4 maneuvers in one, and having them follow one after the other: compression, flexion, rotation over a wide arc with depression at the completion of the rotation. One has to be careful about the rotation of the occiput at the symphysis, so that the anterior blade won't cause damage to the anterior wall and urethra. After rotation to as far as the LOA position, one gives the initial traction downward, bending the handles toward the floor to fix the head in a new position. However, it won't be possible to deliver the baby's head in this position because the blades are upside down. And this calls for the second maneuver of the removal and reapplication of the forceps. Unlock, remove in a downward direction, because that's the direction of the pelvic curve. And the top blade is removed first. Gently. And it is reinverted and found to be the left blade, the one necessary for the reapplication in the new left-sided LOA position. It's held in the left hand, inserted to the left side, inside the splinting blade, between it and the posterior parietal bone. Then the splinting blade is removed, similarly in a downward direction. Reinverted, the right blade, held in the right hand, inserted to the right side, opposite the baby's right ear. Check our application. We have some extension, signified by the anterior fontanelle being 2 fingers breadth above the plane of the shanks. Unlock and elevate one at a time, each handle 2 within the finger's breadth of the perineum. Compress, recheck, apply the traction handle, proceed with traction. Here again, if extreme molding is present and one is afraid that the toes of the Elliott blade are not well anchored below the malar eminences, the forceps may be removed and the Simpson type of instrument applied for the traction. However, in the modified Scanzoni, the side ease maneuver is not a part of it. The other complete instrumental rotation of an occiput posterior is the Dennen key and lock maneuver. It differs from the Scanzoni maneuver in that it is a gradual rotation of the occiput posterior with multiple manipulations over an arc of 135 degrees or more to anterior, and it is done with the Dennen-Simpson type of forceps. The gradual maneuver is necessary because with the Simpson type of forceps, if one tries to execute a complete maneuver with a single motion, is apt to cause injury to the vagina because the Simpson type of forceps have separated shanks and a long tapering cephalic curve. This maneuver perhaps can best be demonstrated with the head outside the pelvis because there are multiple adjustments. And we have the LOP, and we'll consider it to be, for the first step, an ROA, and we'll apply the right blade first. Posteriorly, and it's the right blade to the left ear in this occiput posterior position, and the left blade to the right ear, crossing our handles in order to lock them, and our posterior fontanelle is a finger's breadth below the plane of the shanks this time, since the occiput is posterior. And in the key and lock maneuver, one pushes up slightly, rotates over a small arc, and pulls down. Then the forceps are readjusted one at a time to get a brow mastoid application. The left blade is carried backward towards the mastoid region, and the right blade is carried forward towards the frontal region. Lift up, rotate, pull down. Then readjust again, one at a time, a little further, more of a brow mastoid application. Push up, rotate, pull down. Then the forceps have to be carried around to the opposite brow mastoid position. Then with the next readjustment, it's a partial brow mastoid. Push up, rotate, just a small arc, pull down. And eventually, with readjustment, the blades tend to coincide with the cephalic curve. Push up, rotate, pull down, and we have the biparietal bimalar application and proceed with traction. In our experience, in recent years, this maneuver has not been used. It has been displaced by the special instruments. We've used it in some instances for the transverse position in order to correct faulty applications. The next procedure will be the direct occiput posterior, OP. The posterior fontanelle is between 5 and 7 o'clock. It may be at 6. The question arises as to whether to rotate this occiput to anterior before traction or not. The majority of instances, the rotation is carried out to anterior, either instrumentally or manually. In a small percentage of cases, it's undesirable to rotate to anterior, and should be delivered as an occiput posterior. Those cases usually accompany a deformity of the pelvis involving the transverse diameter, such as those with android and anthropoid tendencies. Those in which the transverse diameter is shortened to such a degree that there's insufficient room to permit anterior rotation. Hence, a direct application of the Simpson type of forceps can be done, the left blade going to the left side, but to the right ear. The right blade to the right side, opposite the left ear. Depress the handles in order to have the shanks as close to the posterior fontanelle as possible, just prior to locking. Reseated, check our application, and proceed with traction. The object is to deliver this occiput by flexion. Deep episiotomy is desirable, and unless one has an anthropoid type of pelvis, one with a long anterior-posterior diameter, it would seem advisable to do a medial lateral episiotomy in order to protect the rectal sphincter. Completing flexion, delivering the occiput by flexion over the perineum. Once it can be controlled with the modified Ritkin maneuver, blades may be removed. And then with fundal pressure, the occiput is expressed over the perineum, and then the head drops down with the forehead coming in under the symphysis as an occiput posterior.